Hello, everybody. Welcome to another edition of our TCOYD podcast. I'm Steve Edelman, and the usual host that usually is my co-host is Dr. Jeremy Pettis, but we have a different Dr. E here. It's Dr. Preethika Ekanayake, and she is an endocrinologist. She trained at UCSD, now is on faculty, and one of her areas of interest and what she's published on is intermittent fasting. And we've had a lot of guests over the years talk about different diets. And I have my theories about those as well. But today we're going to talk about intermittent fasting. So let's welcome Preethika.
Thanks for inviting me.
I appreciate it. So Preethika also wrote an article in our TCOYD newsletter. She gave Endocrine Grand Rounds, which is kind of a huge presentation to everyone on faculty on this. So I think the first question is, how is intermittent fasting different than what we typically think of as just reducing your caloric intake?
Yeah, so there's a difference between kind of continuous calorie restriction and intermittent fasting. So I'll address the calorie restriction and how one would go about doing that. And that's usually kind of what it sounds like. You take a typical American diet that's about 2,000 to 2,500 calories per day and reduce it by maybe 15 to 75%. It's pretty variable depending on the person and what they're comfortable doing. And calorie reduction is without malnutrition or losing necessary vitamins and minerals, obviously.
But Preethika, wouldn't you just say that most people are not successful with that attempt over the long term, which is why someone is always dieting?
Exactly. Yeah, and you got it. But with intermittent fasting, I don't actually consider it as a diet. Calorie reduction could be considered as going on a diet. And I totally agree with you. I think it's very difficult to maintain over a long period of time. And in fact, most of the studies done about, regarding calorie restriction have shown patients have a really hard time, or people in general have a hard time maintaining the lost weight, because often they go right back into gaining weight from kind of incessant hunger. Whereas intermittent fasting, to me, it's kind of like a lifestyle choice. We were talking a little bit before the podcast started about this, that with intermittent fasting, you basically consolidate the time you eat into a shorter number of hours. So you'll be eating for about 7 to 8 hours maybe, and fasting for 16 hours.
Yeah, as you're speaking, I'm thinking that for reduced caloric diets, you're always depriving yourself of something that you normally would like to do. With intermittent fasting, there's no rules on what you can eat, but you're just reducing the time of the day of consuming calories. And has it been shown that people on intermittent fasting diets eat less total calories? I know you're going to talk about how intermittent fasting works, and there are more scientific ways than you might imagine, but do people eat less calories when you restrict the time?
Yeah, you can. You don't have to, but you certainly can, because of that, shifting the time where you eat or when you eat to 7 to 8 hours, you essentially might not eat like 3 big meals, like you would do if you were eating kind of continuously for 12 hours. So you can inadvertently lower the amount of calories you take in, but it's not planned, and you technically don't have to think about calorie counting.
Now, what I'm interested in that I read in your article, which is excellent, by the way, is you have to fast long enough, whatever regimen you're on, we're going to talk about those, to develop ketones. Mm-hmm. Now, to someone with diabetes, you hear ketones, ketoacidosis, that's all bad. Maybe you can help explain that.
Yeah, no, I totally agree. And I think we'll get into how we would instruct our patients, for an example, with type 1 diabetes or type 2 diabetes, or those on the SGLT2 inhibitors, going on this type of a diet. But basically, just to kind of backtrack a little bit, all of us fast when we're sleeping anyway, at least 7 to 8 hours. Maybe not all of us, most of us. So we tend to fast during the time we're sleeping, unless we're sleepwalking and eating or something, which is rare. And Normally, that's about 8 hours. But what I'm talking about with intermittent fasting is if you extend that longer, what happens is this metabolic switch. Our bodies go through using predominantly glucose as the preferred fuel to ketones. So ketones results from us initially breaking down the glucoses and then the stored glucoses from the liver after several more hours. And then finally, when we run out of all that glucose and stored glucose, we end up breaking down fats, which eventually become ketones. And that process take about, anywhere from 12 to some say 36 hours, but that's all depends on the last meal you ate, how big that was.
Yeah, and as I understand it, starvation ketones, let's call it fasting ketones, are quite different than the ketones someone with type 1 diabetes may get if they stop their insulin or their insulin tube comes out. That's a different type of ketones and, of course, more dangerous.
Yeah, so starvation ketones can still be the beta-hydroxybutyrate, like, the ketones we're familiar with the type 1, but it doesn't reach to that very dangerous levels. It could if there are other kind of precipitating factors, like someone's also reducing their insulin or they're sick or they might be on an SGLT2 inhibitor that also promote ketones.
Yeah, and I've seen a lot of people who are just not diabetic. They go out and purchase either ketone meters or strips. Maybe the people starting an Atkins diet, super low carbs, and they want to see that they're producing ketones. And those typically are not dangerous. So, yeah, you have to fast a certain amount of time. And so you say 10 hours, 12 hours minimum. So we're going to talk about the different regimens. But what are some other benefits that you have dug up of intermittent fasting over other diets?
Yeah. So, when you compare calorie reduction and intermittent fasting, there's not much of a difference. It's just with calorie reduction, like we talked about, it's really difficult to maintain over time. So both of those things, intermittent fasting and calorie reduction, lead to better insulin sensitivity, better metabolic parameters, weight loss, improved cognition. So patients on both groups might say that, but it's just the inconvenience of being constantly on a diet with calorie reduction. Now, one thing with intermittent fasting that I find fascinating is they've done some studies looking at calorie reduction, or at least these are meta-analyses, I should say, not research studies.
Well, describe meta-analyses. we don't have too many rocket scientists listening.
So these are just studies that have been done that they've pooled small studies, and someone has reviewed all those studies and obtained results.
Try to get
from
summary
those.
results.
Right, exactly. So what they've seen comparing the continuous calorie reduction to intermittent fasting is our hunger hormone called ghrelin tend to go up quite a bit when we do calorie reduction. Whereas with intermittent fasting, ghrelin or this hunger hormone might be lower and might even be normal. And that's important because that might be the reason this persistent feeling of hunger that we have, our brains have with calorie reduction, that eventually prevent people from being very successful with persistent calorie reduction compared to intermittent fasting. Yeah,
you and I both know the late Dr. Henry talked about ghrelin all the time as he specialized in obesity. And I noticed that with the caloric restriction, being hungry may affect your mood and may do other negative things, may lead to divorce. I know that's pretty serious, but and so you don't get that too much with intermittent fasting. But I think you spoke about a little bit that you do have to go through a period of hunger, and that may go away with time.
Yes. At least the type of intermittent fasting I've done is the time restricted fasting. Now, I know people who've done more alternate day fasting or alternate day modified fasting. And it's the same. As your body get adjusted to the fast period, it's easier to deal with. For me, I think the first couple weeks was really tough on the time restricted fasting because I was constantly hangry. And it probably
that's a cool word.
Yeah, it probably led to almost.
I think that's when you were acting up at work.
Yeah, maybe.
No, Preethika, let's. There's a lot of listeners that are very interested in intermittent fasting. and as I am too, and I've been doing it myself. So let's go through the different types that you outlined in your paper. But I think you called it restricted time intermittent fasting. So we'll start off with what you did, and then what is what classifies as a time restricted fast?
Right. So the intermittent fasting is a big umbrella. So underneath that, you have multiple, permutations you could do. What I found was more simple was doing the time restricted fasting. So I would eat, for an example, from 11 or noon until 6 or 7. That
continuously?
No. Within that window.
You would consume all of your calories in that time.
Within that window, yes. And then I would fast after that. So from, 6 or 7 until the next day, noon.
So you would have, I guess I would call that a slightly early dinner, not too early. And then you eat nothing after that until a late morning lunchtime.
Right, yeah.
And is this something that you kind of did unknowingly as you were growing up in college, making it easier for you to stick to that? Because I'll just you answer that first, and I'll tell you what I do.
Sure. No, my mom used to force feed me breakfast, so that was not me. And breakfast was always like important meal of the day. I was told that too, so definitely not. So it was hard for me to skip breakfast. But after a week or two, I ended up just not wanting breakfast after doing this. So I think it depends. You don't necessarily have to do what I did. I think people could just skip, for an example, dinner, or move the dinner earlier to like 5 or 4, because that tend to, at least studies have shown, finishing your meals earlier in the day tend to improve your metabolic parameters even better.
Improve your sleep.
Yes, and improve your sleep.
Yeah, you know what I think? What I've learned through the years, and I am definitely not an expert, is that people have to find the right, for lack of a better word, diet that fits their lifestyle. And sometimes it's the Mediterranean, and sometimes it's this, sometimes it's intermittent fasting, or a combination. See, for me, I've never been a breakfast person. Now, on the weekends, I like having a typical American breakfast, but later on. But during the weekday, I get up early. I do have a cup of coffee with milk, and then I may not eat anything till 1 or 2 o'clock. And so if I really think about eating, I eat dinner like 7, 8 o'clock. So if I skip the coffee part, 8 p.m. all the way till noon or 1 or 2 o'clock the next day, that's basically 18 hours.
Yeah. And I would say if you can have your coffee maybe without the milk, that would be the fasting.
That would be the ideal.
Yeah. I would be very cranky without my coffee in the morning. So I still have my coffee, but that's not caloric.
Yeah.
So
I mean, I think for me it was easy to do because I just don't like eating breakfast when I get up super early. And I think for anybody listening, they should find the best time of day that they could tolerate fasting at least 12 hours.
Yeah, and I totally agree. And we're talking about times that might sound a little intimidating for some people. For an example, like restricting your eating times to 7 to 8 hours a day might not be feasible for some people. But there have been studies done at UCSD, for an example, looking at men who are overweight with prediabetes, for an example, or metabolic syndrome, and they just restricted their feeding times to 10 hours a day.
Yeah, tell us about that.
Yeah. So small studies, obviously, these, diet studies. So when they looked at patients with metabolic syndrome, but kind of consolidating their eating window to 10 hours, and then the rest of the time, so doing like a 14-hour fast, metabolic parameters, waist circumference went down, insulin sensitivity improved, cholesterol got better, blood pressure got better. So you don't have to necessarily restrict yourself to 7 to 8 hours either to get the benefits.
Yeah, in metabolic syndrome, I think most of you folks know about it from our lectures on our website, but it's a culmination of cardiovascular risk factors that are associated with people with type 2 diabetes. And these folks were they didn't have diabetes yet, but they had the central adiposity, the high blood pressure, the abnormal cholesterol. And I bet you if any of them had either subclinical or real sleep apnea, that had to get better too. So, I mean, to me, it makes perfect sense. But what are some of the other types of intermittent fasting that you outline? Because I think, those give people options of what to do, different days and things like that.
Right. So, if you want to try something besides that time restricted fasting, there's also alternate day fasting, which I would find for myself personally to be difficult. So that's when you eat normally one day and then another day, the next day you fast the whole day. And I just can't imagine doing that.
Not eating anything all day.
Yes.
It like you said, it's an individual thing.
It is. And some people can tolerate it. I could not. So I didn't even want to try that. So that's one that's called alternate day fasting. And then there's another one that's a modification of that called alternate day modified fast. And that's where you would eat normal one day. The next day you would eat 700 calories, something very stringent.
Just a very low calorie diet.
Very low calorie diet, extremely low calorie diet. And then the following day you go back to normal and so on.
See, but that type of intermittent fasting reminds me of caloric restricted because you are doing severe caloric restriction during that period, and then you still have all the issues of reducing your calories. But I think the bottom line is different strokes for different folks.
Yeah.
And what about, periodic fasting? Did you cover that?
Yeah, that one I didn't delve too much into, and I couldn't find a whole lot of studies on it, but it's basically in a given week, you fast 1 or 2 days, and then the rest of the time eat normally.
Yeah. Now, when you tried, when you went on the intermittent fasting yourself, did it work? What were some of your experiences?
Yeah.
And your appetite too? Yeah.
And maybe I should kind of let you know why I did that.
Is there a drum roll coming?
Yeah. So, we had to wear CGMs as fellows to learn and to kind of get some education from our own insulin sensitivity or resistance. And I have a whole long history of family members with type 2 diabetes and early cardiac death. So when I was wearing my CGM, I think it was a Libre or a Dexcom or maybe both, I saw a lot of insulin resistance, even though I don't have yet pre-diabetes or type 2 diabetes. So that was my inspiration to try to do this.
I see.
Yeah.
I see.
But really, the other reason I wanted to do this was because of the non-metabolic benefits that I saw in literature, like improved cognition, for an example. So after the first, I would say 2 weeks where I was hangry, my body just accommodated and it just had no desire for breakfast. And I just felt more like focused at work. Mm-hmm. And I even noticed that now when I have a period where I kind of fall off the wagon and don't do intermittent fasting but go back into it, during the intermittent fasting weeks, I feel a lot more focused at work. And that's like the one thing that I can notice. And I don't know if that's because my brain just want to shift my attention from hunger to, my work.
Yeah.
But it feels just my attention span and focus is a lot improved. I don't know if you tried it and felt something similar.
Yep, I did. There's a thing about, I don't, like I said, I'm not a breakfast person, but, I felt the same thing. One less thing to either be concerned about. Mm-hmm. Now, when I do eat my first meal, I'm starving, but I don't have the hunger. I'm working like crazy, like you do, and I try to just pick a regular size lunch, and I might snack a little bit in the afternoon, and then I have dinner, and then I'm done after dinner. Yeah. And I rarely snack after dinner these days, and I would say that I snack less after dinner than I ever did before I started intermittent fasting. So I don't know if that's ever been shown, but I'm satisfied after that time period.
Yeah, I think people actually have just lower appetite. And I've noticed that in myself. I tend to stress eat a little less because my stomach just feels full.
Yeah. You go to a buffet at the hospital like some nurse is having a baby and they have a buffet. I mean, my willpower is terrible on those. Everything I talk about goes out the window. Well, let's talk about the side effects. I mean, I couldn't think of any side effects, but I know you mentioned a little bit about if you get too many ketones and if you have diabetes. Why don't you talk about that a little bit?
Yeah, and I would actually love to hear, I'll talk about some of it, but I would love to hear your perspective of how you managed. I know you're supposed to ask me questions, but how you managed.
No, you can ask me anything you want. Seriously.
How you manage your type 1 while doing intermittent fasting. But I think the main thing I tell my patients, so when I see my type 2s and type 1 patients in clinic, is if they're interested in trying intermittent fasting, obviously, for the type 2s, I don't worry as much. But if they're on a SGLT2 inhibitor, I do let them know that, if they have any signs or symptoms of ketoacidosis with the SGLT2 inhibitor class plus the fasting, they have to tell me right away, and to not overly reduce their insulin too much unless they're actually going low during that period where they're fasting.
Yeah, just for the listeners, the SGLT2 inhibitors are what you probably know as Jardiance and Farxiga and Invokana. And that group of medications has been shown to cause ketoacidosis in people, primarily with type 1 diabetes, and primarily in people with type 1 with poor control. For me, Preethika, I did lose about 5 pounds, and so I became a little more insulin sensitive. So I did reduce my basal rate, and on my hybrid closed-loop insulin pump, I did change the insulin sensitivity factor to tell my pump that I'm more sensitive to insulin before. But, I feel pretty confident that I'm not worried about ketones. And I actually am on Farxiga to prevent progression of my chronic kidney disease. And so I keep an eye out for that. But, the symptoms of DKA are pretty obvious if you know what to look for, which is just feeling horrible. Right. And sometimes your blood sugar may not be that elevated, but I don't want to get too far off topic. But other than that, I think you're right. For type 2s, it's really not an issue, whether they're on one of these SGLT2 inhibitors or not. I do like it the most, to be honest, because people just don't have to restrict the foods that they grew up with, their ethnic and personal preferences. So with type 1 diabetes, it's just be a little bit cautious, especially if your control's no good and you reduce your insulin too much. And type 2, it's the rare type 2 that can have issues.
Right. And I think, the age we're living in with the automated closed loop pumps makes it a lot easier too, because for an example, in the Control-IQ and Omnipod, there's changes to the basal rate that automatically happen with the better insulin sensitivity. But I do counsel my patients, just like what you did with your pump, to change their insulin sensitivity factor a little bit higher if they're having issues with lows when they're doing intermittent fasting.
Yeah, and what kind of advice would you give any listeners that say to you, and I'm thinking of my girlfriend, Jamie, who, if she doesn't eat something in the morning, and she doesn't eat a lot, but she's got to eat something. Otherwise, she's a wreck. And if she eats too little, she'll be really hungry a short time later. So, people who may not eat that much, but they feel like if they go too long, they need to eat something.
Yeah, I think, like you said earlier, and I totally agree, it doesn't have to be morning. It could be, have your breakfast, have your lunch. If you can move the dinner a little earlier, and a little earlier is if you used to, eat at 7 o'clock, move it to, I usually say 6 o'clock, and then see if you can move it a little bit earlier than that. I think it's about ultimately realistic goals, especially for our type 2 diabetes patients who are struggling with weight issues. So when I have patients who are eating at 9 or 10 and their circadian rhythm is completely out of whack because they're eating so late, and it leads to poor sleep and more fatigue and worsened metabolic parameters, I kind of try to come up with, okay, what will be a better time for you to eat that's not 9? Better time a little earlier. And they might say, well, might be 8. I could do 8. 8 is fine. So we come up with some sort of a compromise to see, would that help their insulin sensitivity?
Yeah. Well, you know what? I'm just thinking out loud that, someone has dinner between 6 and 7, then if they can fast for the next 12 hours, You get up. That's a 12-hour
Yeah,
fast.
right.
So and then if they add on top of that, I'm sure it's hard to do these studies while people do two different type of diets, Mediterranean or low carb. But if you did something else that maybe exchange some of the things that really are caloric dense foods during the period that you are eating, then that's just going to help with more weight loss.
Yeah, they have done things with intermittent fasting and keto diet, and they've shown like very good results in the same metabolic parameters. So it's pretty impressive.
That's awesome. Well, it's been 10 hours and 1 minute since my last meal. So I wanted to sincerely thank you for coming on and doing our podcast today.
Well, thank you so much for inviting me.
And for all our listeners, please check out Preethika's article on our newsletter, which has everything we talked about and a little bit more. And we're going to be also doing a little video on this, and you may see that before you even hear the podcast. So thank you very much.
Thank you.